Hello, today we'll be talking about the treatment of diabetic ketoacidosis in adult patients. And before we dive into this topic, we have to understand diabetes as a disease and how ketoacidosis can occur in such an illness. Okay, so diabetes is a disease that affects how effectively the body uses glucose and insulin. So glucose is a type of simple sugar that the body uses as a fuel source, and it is obtained from digested food. And then insulin now is a hormone here created by the pancreas that you have in your abdominal region that controls the amount of glucose in the bloodstream at any given moment. And in diabetes, the body's ability to produce or respond to the hormone insulin is weakened. And this affects now how effectively the body uses glucose and results in high glucose levels in the blood. So diabetic ketoacidosis, also abbreviated as DKA, is a life-threatening problem that affects people with diabetes, okay? So in this condition, the body cannot use glucose for energy since there is not enough insulin, so it uses then fat for the fuel. And when the body uses fat for energy, chemicals called ketones are released into the bloodstream. However, high levels of ketones in the blood can be a problem because they will cause that the blood becomes acidic, which is a blood pH of less than 7.35. So too much acids now in the blood alters the body's chemical balance, and when the body starts breaking down fat at a rate that is too fast, then this happens. And it is evident in diabetic ketoacidosis that there's an increased acid production leading to an anion gap. The anion gap is a measurement of the difference between the negatively charged and the positively charged electrolytes. And if the anion gap is either too high or too low, it may be a sign of a disorder in your lungs, in the kidneys, or other organs. Okay? So the anion gap is used as a measurement of acid-base balance and can show now when there is an acidosis. This anion gap measurement is essential since metabolic acidosis is often the significant finding in diabetic ketoacidosis. So patients with diabetic ketoacidosis usually present with a serum anion gap of more than 20 millimole per liter. And the precipitating event is what usually sets off this ketoacidosis in diabetes patients. And the most common cause is an infection. And most often it is pneumonia or a urinary tract infection. Also, there can be discontinuation or inadequate insulin therapy to be the cause, or certain medications are also risk factors. And additionally, I would say patients with no prior history of diabetes can have these acute complications as the first sign of diabetes. This is how we find out. So symptoms of diabetic ketoacidosis usually begin suddenly. So they begin suddenly, but they take these symptoms take some hours to really escalate. And it can include fatigue, extreme tiredness, excessive thirst called polydipsia, excessive urination called polyuria, dry mouth, dehydration. And if the person isn't treated, the situation worsens and severe symptoms can occur such as abdominal pain, we have nausea, we have vomiting, we have fruity or acetone breath. We can have rapid and deep breathing, confusion, and even unconsciousness, and this is known as diabetic coma. So people now who have diabetic ketoacidosis will pass some extra glucose and ketones in their urine, which can now be used as a diagnostic sign. And when the patient with diabetic ketoacidosis is taken to the hospital, the first action by the staff is to assess the patient for initial history, carefully, physically examine the patient, and this includes vital signs. We have cardiorespiratory status, the mental status, the volume status such as skin turgor, mucosa, urine output are also evaluated, followed by some lab tests. And these lab tests include blood glucose, urinalysis, urine ketones, blood electrolytes, blood urine nitrogen, creatinine, plasma osmolality, venous blood gas, and ECG. And if there are ketones in the urine now, ketones in the blood are also analyzed. And often the dehydration and potassium deficits can be very severe. So additional testing is obtained based on some clinical circumstances and may include we have blood or urine cultures, we have lipase, chest x-ray, and further testing such as cultures of urine, cultures of sputum and the blood. We have serum lipase and amylase, and as we said, chest x-ray should be performed on a case-by-case basis, as these tests may reveal an infection even if there's no fever. So, glycated hemoglobin or A1C measurement may also help determine whether the acute episode of some previously undiagnosed, poorly controlled diabetes, or is it a genuinely acute attack now in an otherwise well-controlled patient? So this is the question here. And the diagnostic criteria for this diabetic ketoacidosis are the triad, so three things, of hyperglycemia, anion gap metabolic acidosis, and ketonemia. The metabolic acidosis is often a significant finding, and the serum glucose concentration is usually less than 800 milligram per deciliter or less than 44 millimole per liter, and between usually 350 to 500 milligram per deciliter or 19.4 to 27.8 millimole per liter. Now we check the history of the patient, and in specific settings such as starvation and pregnancy, these can also alter their blood glucose levels. So we need to ask the patient of that. So the treatment now of diabetic ketoacidosis, the foremost action now in management to stabilize the patient's airway, breathing and circulation, so ABC. And the crucial part of treating the patient is determining and treating any underlying cause. And the treatment involves correction of the fluid and electrolyte. That is the most important thing, because these are very typically present, and these are hyperosmolality, a high concentration of substances in the blood. We can also have hypovolemia, which is a decrease of volume of circulating blood in the body, and we have metabolic acidosis. Correcting now potassium depletion and the administration of insulin is very important also. So we have to frequently monitor. We use cardiac monitoring, capnography and pulse oximetry, and the patient's blood glucose and essential electrolytes should be checked every hour. And so when we check the basic chemistry, for example the pH or bicarbonate, this can be checked every 2 to 4 hours, and then we do that until the patient is stable. And the course of ketoacidemia, so acidic ketones in the blood, this can be assessed by direct measurement of the beta-hydroxybutyrate, which is the major circulating keto acid. And also the measurement of the serum anion gap can indicate the extent of this ketoacidemia. And it's important to note that nitroprusside tablets should not be used, since they react with acetoacetate and acetone, but not with beta-hydroxybutyrate. This is a very misconception. So acetone is a biochemically neutral and does not contribute to ketoacidosis. And to correct both hypovolemia now and hyperosmolality, we need to give fluid. That's the important thing. And this fluid replacement would correct estimated deficits within the first 24 hours when given with some caution. Isotonic saline solution should be infused very quickly because patients with hypovolemia and shock need this treatment very quickly. And we give 0.9% isotonic saline solution at the rate of 15 to 20 millimole per kilogram per hour, or approximately 1000 milliliter per hour in an average sized person. And this 0.9% isotonic saline should be infused for the first couple of hours, and after it should be followed by 1/2 isotonic saline at the rate of approximately 250 to 500 milliliter per hour if the serum sodium is normal or elevated. And note that isotonic saline should be continued now at a rate of roughly 250 to 500 milliliter per hour if hyponatremia or low blood sodium is present. Dextrose should also be added to the saline solution when the serum glucose reaches 200 milligram per deciliter or 11.1 millimole per liter in diabetic ketoacidosis. So we need to add potassium to potassium depleted patients, and we give 1/2 of isotonic saline, since adding potassium to isotonic saline forms a hypertonic solution that can worsen the underlying hyperosmolality. So caution is needed here. The recommended initial treatment with insulin is a low-dose intravenous infusion, and this insulin treatment applies to all patients with moderate to severe diabetic ketoacidosis who have serum potassium of more than 3.3 millimole per liter. However, patients with initial serum potassium below 3.3 millimole per liter should receive aggressive fluid and potassium replacement before we start treating with insulin. So if the serum potassium is more than 3.3 millimole per liter, we give a continuous intravenous infusion of regular insulin at about 0.14 units per kilogram per hour. And note that at this dose, an initial intravenous bolus is not necessary. However, an alternative option is to administer an intravenous bolus of 0.1 units per kilogram body weight of regular insulin, followed by a continuous infusion at a dose of 0.1 units per kilogram per hour. And then the amount is doubled if the glucose does not fall by 50 to 70 milligram per deciliter, or 2.8 to 3.9 millimole per liter in the first hour. In mild diabetic ketoacidosis, there is a more cost-effective alternative to intravenous insulin. In such a case, the initial treatment of mild can be treated using a subcutaneous rapid-acting insulin analog such as insulin Lispro or Aspart or Glulicin. However, now caution is required for selected patients in such a setting, and adequate monitoring should be assured. Okay, so in patients with diabetic ketoacidosis, the initial serum potassium concentration is often normal or elevated. This is very good. However, this would be reversed by the insulin therapy. So intravenous potassium chloride should be initiated when the serum potassium concentration is less than 5.3 millimole per liter. And it is recommended that patients with initial serum potassium below 3.3 millimole per liter should receive aggressive fluid and potassium replacement, as we said, before we start the treatment with insulin to prevent any initial worsening of the hypokalemia. So, sodium bicarbonate therapy can be used to help correct metabolic acidosis. However, the research on this type of treatment is very controversial. However, now we can say in patients with an arterial pH of less than 6.9, the treatment with intravenous sodium bicarbonate would actually be beneficial. And also, despite the whole body phosphate depletion being a common feature in this disease, we do not administer phosphate routinely. So rather, phosphate replacement should be for patients with a very, very severe hypophosphatemia or respiratory or cardiac failure or hemolytic anemia. The ketoacidosis is resolved when there is a normalization of the serum anion gap to less than 12 millimole per liter when the blood beta-hydroxybutyrate levels are normal, and if available then. And also when the ketoacidosis has resolved now and the patient can eat, it is often the case now to initiate a multiple dose, so basal bolus subcutaneous insulin schedule again, and the complications in the treatment of diabetic ketoacidosis can include, we have cerebral edema, we have pulmonary edema. Cerebral edema is an excess of accumulation in fluid in the intracellular or extracellular space of the brain, and it typically causes an impaired nerve function, an increased pressure within the skull, and it eventually can lead to direct compression of the brain tissues and blood vessels. So it is rare in adults, but it is associated with very high rates of morbidity and mortality. Possible preventative measures now in high-risk patients include gradual rather than rapid correction of fluid and sodium deficits, and maintaining slightly elevated serum glucose until the patient is stable. Non-cardiac pulmonary edema is fluid accumulation in the tissue and in the air spaces of the lungs, and that can lead to impaired gas exchange and may cause respiratory failure. So pulmonary edema and hypoxemia can complicate the treatment of diabetic ketoacidosis. Hypoxemia is attributed to a reduction in the colloid osmotic pressure, resulting in an increased lung water content and decreased lung compliance. And patients with diabetic ketoacidosis who are found to have a wide alveolar arterial oxygen gradient, please check that out, I will not talk about that here, and rails may be a high risk of developing pulmonary edema, so these patients. To summarize now all these fancy words, we can say now, we have talked about the diagnosis and the risk factors and the management and so on. The foremost action in therapy is to stabilize the patients. We stabilize it with ABC, airway, breathing, and circulation, while we determine and treat the underlying cause. Okay? The treatment involves correcting the fluid and the electrolytes, And typically we have a hyperosmolality and a hypovolemia and metabolic acidosis. Correcting the potassium depletion and the administration of insulin is very important in this disease. And frequent monitoring is essential with the cardiac monitoring. We have capnography and pulse oximetry. And the patient's blood glucose is essential now because we need to check the glucose, we need to check the electrolytes, and we check that every hour. The other ones, the pH, the bicarbonate, that can be checked every 2 to 4 hours until the patient is stable. The course now of ketoacidemia and acidic ketones in the blood can be assessed by direct measurement of beta-hydroxybutyrate. The correction of fluid, the correction of electrolyte abnormalities involves caution. So not too quickly, but this is the dilemma, but we need to give intravenous fluid replacement to correct the deficits. We need to correct it within the first 24 hours. Therefore, we need to check the blood very routinely. And isotonic saline should be infused now as quickly as possible in patients with hypovolemic shock. And in hypovolemic patients without shock and with heart failure, we give the 0.9% isotonic saline with a rate of 15 to 20 milliliter per kilogram per hour, or approximately 1000 milliliter per hour in an average sized person. The recommended initial treatment with insulin is a low-dose intravenous fusion that applies to patients with moderate to severe diabetic ketoacidosis who have serum potassium of around more than 3.3 millimole per liter. However, now, patients with initial serum potassium below 3.3 millimole per liter should receive aggressive fluid and potassium replacement before we start treating with insulin. And suppose now that the potassium is more than the 3.3, then a continuous intravenous infusion of regular insulin at the 0.14 unit per kilogram per hour can be administered, or we can give an intravenous bolus of 0.1 unit per kilogram and then followed by continuous infusion of 0.1 unit per kilogram per hour. And then the amount is doubled if the glucose does not fall by 50 to 70 milligram per deciliter in the first hour, In mild diabetic ketoacidosis, the alternative is to have intravenous insulin subcutaneously with rapid-acting insulin analogs such as Lispro, Aspart, or Glulicin. The insulin therapy will create the need for potassium replacement, so intravenous potassium chloride should be initiated when the serum potassium concentration is less than 5.3 millimole per liter. And if the initial serum potassium is below 3.3 millimole per liter, they should receive aggressive fluid, as we said, aggressive potassium replacement before we start with insulin to prevent any initial worsening of the hypokalemia. Sodium bicarbonate therapy, as we said, can correct metabolic acidosis, particularly in patients with an arterial pH of less than 6.9. And phosphate should not be given routinely. However, phosphate replacement should be for patients with very, very severe hypophosphatemia or very severe respiratory failure or cardiac failure or hemolytic anemia. And rare complications that we need to mention in the treatment of diabetic ketoacidosis, as we said, was cerebral edema and pulmonary edema. And I would say thank you very much for listening. I know that this topic is very confusing, and I know that it's hard to grasp many words that I'm saying, but unfortunately I cannot deal with all the facts, all the words separately. You somehow need to watch the video, look up the words in Google, and maybe you will understand what I'm talking about if you watch the video a couple of times. So whenever I'm saying, for example, that when you give insulin, then why is it important for that's the question you can ask. Why is it important to add potassium? And the reason why is because insulin tries to move potassium from blood into the cells. So if the patient is coming, as we said, with this level of less than 3.3 millimole per liter of potassium, and we start to give insulin, what happens is that it drops even more. And as we know, potassium below 3.5 is actually is actually a problem, because when we get to the level of 3 and below 3, 2.5 to 3, that's very severe and the patient can actually die. So I think the main parts that I'm saying here needs to be checked in Google and needs to be checked with my other videos, and then you will understand what I'm meaning. It's a global picture, because I'm assuming that you understand what I'm saying, that please give potassium and fluid to a patient who has a potassium level of less than 3.3. I'm assuming that, but I realize now that we need to be careful when we talk about that, and don't explain it in a very understandable way. So to make things clear now, fluid, so diabetic ketoacidosis treatment, fluid, especially with a patient with hypovolemias or low level of blood pressure, and then potassium, especially patients with low potassium, and insulin, because we have a high glucose here. So these are the three main things I would say that you need to remember: fluid, potassium, and insulin, and actually in this order, especially if as we said, potassium is low. I thank you very much for listening. Take care. Bye bye.